So imaging is used for the diagnosis of metastatic prostate cancer in many different ways. We can be looking for solid organ metastatic disease as well as bone metastatic disease. Depending on the situation with the PSA, we may be looking at different areas. So the different modalities that are available inside of the armamentarium of the radiologist as well as the oncologist is CT, PET-CT, MRI, and then also some multiparametric MRI of the prostate. Decision tree about when to do imaging in patients with metastatic prostate cancer is dependent kind of on local patterns as well as some of the national guidelines. I think one of the key things we have to be looking at is what kind of treatment has the patient had, what is their PSA trajectory, and what is our level of suspicion that they have metastatic disease, whether that be clinical symptoms, etc. So some people are advocating using CT or PET-CT at intervals every 6 to 12 months. I think that it really has to be personalized depending on the patient's PSA situations and also looking at some of the national guidelines. One of the things about prostate cancer is every patient's very unique, and so some of the experiences that we've had have shown me that some people manifest their disease in very, very different ways. And so I think choosing the right imaging modality is as critical as how often we do the imaging. And so trying to identify where the most suspected site of recurrence is going to be, is that going to be a widely metastatic disease or an oligometastatic disease pattern, is extremely important. So I think choosing the imaging modality is really, really critical in assessing it. And with some of the new advents in technology out there with regard to new types of PET technology, I think it's a very exciting time to be able to offer these types of modalities to our patients. So the patient that we talk about in this case here is really interesting in the fact that they had what was suspected to be low-grade disease, and then they were on active surveillance for a long time. Once a decision was made to actually pursue more active treatment, part of that was informed by a biopsy change that had shown that they actually had more aggressive disease. And I think that that's a potential place where we could implement something like multiparametric MRI to assist. The ability of multiparametric MRI is really to inform decision-making by talking about the degree and grade of tumor, as well as the possibility of extraprostatic extension. So I think that that's one place where we could have implemented imaging. I think that the guidelines are stating to us that in patients with PSAs below a certain level, CTs really aren't that helpful in assessing for metastatic disease and specifically assessing for local progression of disease. So I think before the metastatic disease, multiparametric MRI could be a very helpful technique for assessing the grade of this person's tumor. After the development of metastatic disease, I think the critical aspects about determining the intervals for imaging should be the PSA and also symptomatology from a clinical standpoint. So if this patient's developed bony metastatic disease, as we've seen on both the CT as well as on the PET scan, we want to ensure that should the patient's symptoms worsen at all, we image them to make sure that they don't have any complications of these metastatic disease in their bones. In addition, we want to make sure that we have enough cross-sectional imaging as well to ensure about the presence or absence of lymph node metastatic disease and also solid organ metastatic disease as well. I think multidisciplinary care is at the very heart of prostate cancer care and really all oncology care right now. I think I feel very fortunate to be part of a group that talks about cases at length when we have patients come in, and really the patient comes to one room and all of us rotate around that patient. In that that discussion can be extremely helpful. The radiologist providing some guidance as to what imaging tests are available, the oncologist providing some guidance as to what they might be looking for, the radiation oncologist and the urologist being informed and being aware of what the possible options are with regards to treatment. So I think it's a really helpful thing, and I think that it's hopefully where prostate cancer care is going all over the world. The most critical thing in regards to multidisciplinary collaboration is communication and having regular meetings where we get a chance to talk about these patients, how they're doing, and also how each of our groups can assist the other, I think is the most critical part of coordinating care. I think having tumor boards as well as multidisciplinary case conferences where these more straightforward cases are discussed, but also the more difficult cases are discussed is extremely helpful, and I think will really help our patients.